Welcome to Girls Gone Wellness, Dr. White.
Hello, thanks for having me.
Of course, we are super excited to have you. Most people probably by now know that this is like one of my favorite things to talk about. And we both know that you are just such a force in this field. And so we're really excited to pick your brain today. Let's start with telling us a little bit about your journey into medicine and specifically your interest in the weight management space.
Totally. My interest in weight management predates my life as a doctor by like 20 years, potentially
Wow.
before that. I started dieting when I was a really young kid. I was around a lot of dieting. Dieting was normalized in my community, like in terms of my close community as a child.
Hmm.
My body was the subject of critique and observation and public commentary from a very young age. I grew up in a really small town. I'm a very tall person, and I grew very fast. So I always looked quite a bit older than I was. And for most of my childhood and for various, eras of my life, I've been in a larger body, um, larger and smaller. If you took a picture of me at, you know, 1 year or one time every year for the last 40 years, there are times in which I am not easily recognized as myself. And so when your body becomes the subject of like just people's thoughts and the things they say out loud when you are a child, you or I would say at that time in the 90s, I self-objectified. And by that, I mean, I adopted the gaze of others in seeing myself and started very young to decide that I probably shouldn't be fat. I shouldn't be large. And that was a problem. And though many other things in my life came easily, academics, friendships, sports, I was very fortunate and gifted. Um, I was always aware of my size and how that was a barrier to acceptance in so many places and so many spaces. So I started reading diet books when I was a really young child and trying to implement them um, through all sorts of means. So name a diet, and I've done it. Name a lifestyle or food way, and I've done it. Usually in an attempt to both be healthier and to also lose weight, because I adopted the axiom that being heavy was unhealthy. Full stop, without further nuance.
Hmm.
I know that's untrue. Um, Studied a lot of nutrition. I was like the person who in high school like took nutrition courses like for fun. So I've always been very interested in food physiology, exercise physiology. It's always been an area of like great curiosity for me, independent of my own struggles. I was a varsity athlete. I was in the rowing team as an undergraduate university student, and around the same time developed anorexia nervosa, became quite ill, and it was the several years of recovery, and was curiously, I discovered that the self objectification and the extent of the discomfort around food didn't actually go away as I got larger. And I got better, I got healthier, I got more mature, I had a better perspective on everything. I started learning uh, a much gentler way of being with myself, and it's like just has it's gone just up every year. I just get better at
Hmm.
knowing myself and caring for myself. And you just like once you decide that that's how you're going to live your life, you kind of just never stop, which is wonderful. um,
Hmm.
and then I did grad school, and then I did a bunch of jobs in public health, and then I decided I should go to medical school. I had already been rejected twice, but I was like, no, 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 I'm actually serious this time. I got to do it. And then I got in to McMaster, and so gained a lot of weight throughout medical school because it's a really unhealthy time of one's life.
Hmm.
And then I went kind of full bore into comprehensive rural generalism. Worked a lot. Did not care for myself in a way that I wish I hadn't. Um, and reached my highest weight within a few years of starting my practice, and went to a weight loss specialist, a doctor, for the first time. I had no expectations of any form of success because all I had seen is failure. And all I had seen is that I can either be very, very hungry or I can be fat. Those are my options. And that's a really difficult place to be. And as you get older and you start to actually like yourself, you decide you're not really actually willing to starve yourself. And so you just kind of think, okay, well, I suppose I'm just going to be fat. And okay, actually that's okay, right? However, I ended up with HELP syndrome with my first pregnancy at my highest weight. Atypical HELP. I had no high blood pressure. My blood work was perfect. I've always had low cholesterol. Metabolically, I've always been quite healthy at any weight, mostly because of my commitment to athletics. But obviously I had placental insufficiency because I developed fulminant liver failure the day I was due to deliver my daughter. And
gosh.
yeah, I mean, I was okay. I was rushed to hospital. I diagnosed myself because of my atypical presentation. It was very strange. And everything was fine. However, it was a bit of a metabolic wake up. And my highest weight, my weight actually I just like didn't really lose much pregnancy weight because I didn't actually have much of a postpartum window. I went back to work at 10 weeks.
Wow.
It was a really difficult time. And then the pandemic started when my daughter was 5 months old and I was an emergency physician.
My gosh.
So I was very fortunate to encounter this weight loss doctor who said, oh, by the way, this disease is not what you think it is. And he sort of opened the door. But I walked through it and also realized there were like 14 or 15 other doors. And then I kept just opening doors in my practice with myself, but with like thousands of people that I worked with. And I was like, oh, we're doing this all wrong, like very wrong. We are about to have some of the most powerful therapeutics we've ever had for any chronic disease, for a disease that has a 40% adult prevalence. And our system is so underdeveloped to properly care for people with obesity. I had a master's in public health, a medical degree, 3 years in practice at that point, had lived all over the world, had studied nutrition since I was a child, and had already gone through like birth and so many things in terms of my own health. And I still needed to teach myself the things I needed to know. And I thought, this will never work. We will dump these molecules, these really useful, really important molecules, into a system that will have not a clue what to do. They will end up in the hands of people who are stuck in a loop of self-objectification. They will use them to underfuel and to facilitate underfueling. And as a person who I know the disease of anorexia. I know this disease. I lived it. It was in my brain for a very long time. There is always a familiarity with the occasional gratification that comes with restriction. I decided to feed myself, but lots of people don't make that decision.
Yeah.
And they are faced with the same fork in the road. I believe if we do this right, that's not a fork in the road. You can be satiated and satisfied and have the pleasure of food and also have metabolic well-being if done well. So my mission is to empower patients to understand their own mind, to commit to seeing themselves as beautiful living ecosystems, interacting with other ecosystems, and to understand the role of modern therapeutics like GLP-1 receptor agonists, like combo molecules like bupropion, naltrexone, and many other tools in their lives, but to make decisions, well-rounded, smart, and long-term decisions about their health so that their weight can stay in a territory that allows them to live like really good lives. That's the job. I cannot do that by asking nicely. It hasn't worked. I will not ask hospital systems to figure this out. The Ontario Bariatric Network, the Ontario Bariatric Program of Care, is not an effective pathway for the care of people with overweight and obesity. it is, I would say, my kind assessment is that it is incomplete. The
Mm.
problem it is that it is incomplete and very expensive to the taxpayer, which is a concern
Right.
of mine. This I will not ask large clinics, and I will not ask the government to adequately fund comprehensive primary care for the adequate training of dietitians and nurse practitioners and medical
Right.
doctors, because they've consistently shown a lack of interest in treating this like a real problem.
Mm.
And so I'm just working adjacent to the system to do it well.
Yeah. I feel like that is the best, most comprehensive answer I've ever received to asking somebody about their passion. Like, seriously, like, incredible. Thank you for sharing that.
It's
Mhm.
not an elevator pitch because it takes like 10
No.
minutes. But, uh,
I was gonna say, I was thinking, I was like, you need to get a TED Talk. We need to get you in
Yeah.
contacts to whoever does those, honestly.
we're working on it.
Yeah. I feel like with your story, thank you for sharing that. Growing up, we actually have a very similar, it seems like, childhood experience.
We're not
Where,
alone.
yeah. And, I grew up in a much larger body and I struggled with the same things. And I remember thinking that it doesn't really matter academics and all the other things I have going for me because it seemed like the most important thing I'll ever do in my life is be small. And
And
then,
the
mhm,
world reinforces it because
Mm.
you become more visible, more
yeah,
important,
yeah,
more intelligent, more
hmm,
successful in a smaller body.
absolutely. And
That's
then,
that's not real, but
no,
there are actually like it is the reality of our world.
hmm,
And
Mhm.
that's not fair. And that's weight bias going both ways.
absolutely. And then you go to naturopathic medical school and it's
How'd that go?
reinforced.
It's reinforced.
And then all of a
Mhm.
sudden we have the opposite problem, similar to what you were saying with an eating disorder. Because
Yeah.
it's like there's just no middle ground here. And like you were saying, there's this massive gap. And instead of us just waiting for everyone else to solve it, it's like if you want something done, you got to get it done. And I feel
Right.
like that's exactly what you're doing.
And
And
it
so we
speaks to the
really
power of
appreciate
lived
that.
experience.
Hmm.
My patients, many don't know about my history.
Yeah.
Um, and it goes like it's layers, like the generation above me, like we have a genetic uh, obesity syndrome in my family. I didn't know that
Hmm.
until I had to like really piece that together myself because that's not it's just not it's not known. But my patients who don't know my lived experience, they sort of say like you're in my head, and I'm like, well, yeah, I am. I know this.
Right.
I know what it is like to live the gamut of this.
Hmm.
And therefore, I know that it is not a vanity thing. It's not it's just a couple pounds thing.
Yeah.
Or lighten up, have a chocolate bar. Like that. It's not that. It's that there are places and spaces you can only go in certain bodies. And also, sometimes your quality of life is higher when you are not dealing with disease associated with either end of the spectrum.
Yeah.
Mhm.
And that's real. I believe we can be really thoughtful and nuanced about the desire and intention to lose weight and then to regulate weight and in the middle,
Hmm.
while also acknowledging that the pressure to conform and to be thin is devastating. Those are
Hmm.
both real things. We are adults and we can hold both of those things as true.
I love that you said that. It's so, so true. I think that a big thing, I mean, obviously, we know weight stigma is huge, both in the medical field and just in society. And you do, like, still to this day, even in the medical field, there's a lot of like questioning of someone's willpower and questioning like well
Mhm.
why can't you just eat less, like why are you over consuming calories, and there's just kind of this idea that it's somebody's fault
Yeah.
when they're overweight or obese. And recently I've become so fascinated in the world of like the genetic piece, but also just how the brain regulates our appetite. I think it's so incredibly fascinating, and it pulls us away from that idea of like, well, you're eating too many carbs, to like, this is a real thing happening, and we want to actually truly help you.
Mhm.
And I gotta know, I want to pick your brain on this. Like, what is the role of the brain in appetite and in weight management? And, is willpower a part of this at all?
Yeah. So willpower is a thing, but it's not the thing we think it is.
Mhm.
um, so the the doctor that I went to when I was like, okay, I think I need to lose weight here. Like, this is a real thing. My placenta obviously didn't want to work for the last week of my pregnancy, so that's a problem. Um,
Right.
the doctor I went with has presented what is a public facing sort of basic skeleton model of the human appetite for moments like this when we're trying to communicate to patients, what is it? So he talks about the executive or the pilot. He talks about the homeostatic appetite system, and he talks about the
Mhm.
hedonic appetite system. And even that is actually relatively simplistic and reductionist. So what the tricky part for clinicians is to um, offer a true explanation to a patient that is understandable, but
Mhm.
also leaves room for the fact that this is going to grow and change. And our understanding is essentially evolving every month at this point.
Mhm.
So, what I think really matters is that our brain has the responsibility to integrate all sorts of data. That data is coming from our blood because the hypothalamus is in direct contact with the bloodstream. It actually has like little windows. I imagine it with like little binoculars, like looking at the venous system and the arterial system, being like, "Ooh, look, we're low on B12. Okay," like actually, or "Oh, there's not enough glucose. Oh my goodness." I think of like that movie Inside Out. You got like,
Yeah.
and like that's the appetite. It's just happening in there.
Mm.
And I think about our reward system, so our mesocortical limbic system that governs our experience of wanting and desire and pleasure. Those are
Mhm.
wanting and liking. And what is really important about how the brain regulates everything is that our we rely a lot on learning. So every time we want something, it's because historically something from our past taught us that it was wantable. It was the thing that we liked that felt good. And the
Mhm.
feeling good part is governed by our opioid receptors mostly, but the wanting it, the going for it, is governed by our dopamine receptors. Then there's what happens in the prefrontal cortex, which is where we, over time, as we become adults, develop the ability to manage the system. To say, yeah, I would like to stay up all night and have like 10 bags of licorice. I would have liked all of those things. That
My
would be great.
gosh.
But like, okay, you need to go to bed.
Yeah.
Perhaps it's a good thing to do for your future self to like plan what you might want to wear tomorrow. Like just like these really like these things that we do that we don't want to do. That's our
Yeah.
prefrontal cortex.
Mhm.
So what we understand is that there are lots of people who have the ability to deploy high levels of cognitive control over cravings and wanting and impulses, right? Those people can say things like, well, I had a cookie and it was nice, and then I put the box away. And those people also, in addition to just sort of having a lot of cognitive control, they also are people who have learned in the past that it's good and rewarding to exercise cognitive control. So when
Mhm.
they show up on time to meetings, which I am like incapable of doing, when they like no
Same.
idea what happens, when they study at exactly the right time of the day to
Mhm.
optimize their energy. Like these are people who are just like, they've got it sorted. And so willpower is not just like white knuckling, like, I'm going to try
Right.
really hard.
Yeah.
Because no, it's actually the exertion of cognitive control. It is something that gets easier as we get older with practice. It is something that needs to be done outside of a highly stressful situation. Because if you ask your brain to exert cognitive control in a situation where you've only ever responded with impulse and I want it now, without giving it the framework for how to do that, to override our inner demon in honor of our greater good, then it's not going to work. And what we will have learned is that we are failures because we can't do this thing that is impossible to do, but we just magically said, oh, we're going to do it. And also we're going to do it hungry.
Yep.
Which you're not going to be able to do.
Yep.
So the ability to exert cognitive control over your life, over everything, your relationships, your performance in any domain, like you have to be slept, you have to be fed, you have to have enough sugar in your brain, you have to be loved, you have to be connected to people, you have to be safe. So we talk about willpower, but we're asking really hurt brains, scared brains, child brains to do something that they have never learned to do. And we're asking them to do it in a sympathetic context, a nervous system activation context that is not safe. And it's impossible. Can't do it. All diets recreate that exact setup. Diets take away people's belonging. They take away their autonomy. They make them feel incompetent. They threaten them. They starve them. And so when I hear people are like, oh, I just went like keto, it means you just like fired up that nervous system real hard. And it's going to feel okay for a bit because you're going to have some early wins. You're going to ride that dopamine. It's going to be, or the opioid. You're just going to feel a little bit of mastery, and mastery feels good. Yeah. But it's going to backfire. So a lot of my job as a person, it's one of the reasons I call myself a metabolic strategist, is because I need to take the reins of someone's prefrontal cortex for a little bit and be like, all right, let's just hold on. What are the risks we see on the horizon? What are the goals we have on the horizon? I need to draw their conscious attention to the goalpost while also making them feel really safe and really calm and really okay, and making them feel like they've not done anything wrong because they haven't. And when you do that, all of a sudden their heart rate goes down, their posture relaxes. They actually start burning more calories. They start, their metabolic rate will improve, and their food seeking will go down because they are safe. And their food seeking for highly palatable foods, highly like quickly available energy will go down because they are safe. And so I start by instilling safety and identifying threats to safety, which is why my assessments take forever and I'm always
late. We've talked about this.
Ask the team, ask the poor admin at my clinic. They're like, oh my God.
I don't think I've ever been on time to a recording before, so I can I can attest to that.
Yeah, the prefrontal cortex does a lot of stuff. It does not do that.
I would love your take on this because, and excuse me if I'm being ignorant in this space while I try to talk through it, but we did have Dr. Spencer Nadolsky on our podcast, and he said something really interesting that really stuck with me from my understanding. Yeah.
Like, yes.
He's awesome. He's awesome. The way that he kind of talked about this really stuck with me, and I would love your take on it as well. But he basically was saying that when people have obesity, it's very similar to any sort of addiction, like whether it be alcohol, whether it be shopping, whether it be like sex addiction. He said all of this, and I was wondering, like, in your experience, like, is this what you see? Is this what's going on in the brain? Because I think if people can make those connections, people can emphasize a little bit better.
So I really like using these two diseases as a compare and contrast because it says a lot about, you know, what's nature, what's nurture, what is because of stigma, like, I think it's really important to compare addiction and obesity in lots of different ways. And there are so many commonalities, but there are crucial distinctions.
Mhm.
I used to actually practice a lot of addictions medicine. In addition to my family, one arm of my family has a lot of obesity and metabolic disturbance and hyperphagia, which is eating sort of far beyond a point of caloric need, including myself as a young person. And then another side of my family has widespread, very severe addiction of, pick your poison.
Yeah.
And has had catastrophic family consequences for that side of my family. And so I initially, my master's degree really focused on the experiences of women who sell sex and use drugs. So I've been really engaged in the neuroscience of addiction for quite a long time, even since before medicine. So these two conditions come to mind a lot for me. An important area of commonality is that they are both treated as choices by our system.
Right.
The evidence-based treatments for these conditions are both subject to a lot of stigma, and they are both subject to a lot of, well, why would we fund that? They just need to try harder.
Yes.
Common. Stigma towards people with obesity and people with addiction are two of the most socially acceptable forms of stigma, and then discrimination on both sides. These conditions play out very differently. Sometimes people say, well, you have to eat food. You don't need to use fentanyl. You don't need to use alcohol. But the brain doesn't know that because it's learned that it needs those things.
Yeah.
So those are not helpful distinctions, in my opinion. The other thing, when it comes to like the pure, what do psychiatric researchers say about the distinction, is they want to look at the role of tolerance. So one of the important diagnostic criteria for addiction is the presence of tolerance. So you need more of that substance over time to create the same effect. So what you see is the upregulation of opioid receptors, GABA receptors, things like this. Depending on this, it's substance dependent. And you can see this with all substance addictions. It's less clear that there is a similar form of tolerance that is developed with food. Because of course, we need glucose. So, and also it's extreme because all macronutrients, most of the time we're eating them in combination. Tolerance for what? Like tolerance for sugar? Like tolerance for protein? Like what are we talking about? We do see insulin resistance, which is a form of upregulated receptor activity, right? So is that tolerance? Is it about people's palates? Like do people's, and we do know that people's palate over time, when exposed to ultra-processed foods or sort of when in a weight acceleration loop, their palate can be altered and favor ultra-processed foods, and to the exclusion of non-processed foods. Actually, like their palate is not geared towards fibrous food because it's just not that exciting, right? And so when Dr. Nadolsky, I only read his name. I actually don't have to pronounce his name very often.
He didn't even know how to pronounce his last name. He's like, I don't even know how to pronounce it. So
somewhere in Eastern Europe, many eons ago, someone made his name up. Yeah, my husband is white. So it is like addiction in that people can feel very much trapped by their subconscious, and the gap between what they want to do and what they are doing is large, and they don't understand why. So is that there's much more, but does that help settle some of that tension? And it's why we actually do see lots of overlap and we see substitution, right? So when people quit drinking, and
they
sort of
switch.
the joke in my family is who's on the wagon and who's not, right? Because they pack on a few pounds around the belly when they're not drinking because they're eating more. And sometimes it just means they're eating it all, right? Because usually there is what we call anorexia, not anorexia nervosa, but like lack of eating in people who are preferentially pursuing substances.
Right. Mm-hmm. That's really fascinating. No, I'm glad we touched on that.
Mhm.
You had mentioned genetics. You'd mentioned that you have a genetic condition in your family.
Yeah, so it's really important to clarify the kinds of ways in which genetics influence weight. So
Yeah.
there are some rare obesity syndromes that we know when people are carriers of two copies of the gene for that thing.
Right.
They so some of them are homozygous, but some of them are only require they're autosomal dominant transmission, so they only require one copy.
Mm-hmm.
They develop syndromes that are the most common trait that you see in these syndromes is hyperphagia. So you see people who have a very powerful drive to eat and they
Right.
don't experience satiety very easily, or if they do, it's very temporary. These people end up at very, very high BMIs and they end up at very high BMIs very young. And so they are usually knowable. In addition, depending on the kind of condition, they can have other abnormalities, including vision, kidney. It really actually does. Intellectual disabilities is commonly seen, and three of these happen sort of north of the MC4R receptor in the brain. So at the junction of where leptin intersects with the AGRP system or the hunger system,
Mm-hmm.
and then upstream of that is something called the MC4R receptor. MC4R receptor deficiency is a condition characterized by hyperphagia, very high BMIs. It does not come with intellectual disability. Notably, it comes with high levels of insulin resistance. It comes with accelerated height acquisition. And if you look at my family, we have always felt as though we were giants, and we are. And high bone density. I broke both of my wrists on Christmas Eve 2 years ago. And I'm, early perimenopause woman who had several years of her life where she was underfueled and
Mm-hmm.
certainly at least calcium and vitamin D deficient, if anything.
Yeah.
And I broke them both. And the orthopedic surgeon looked at me and he said, "You have the bones of a manual laborer. I have thick bones." And I
Mm.
was like, "Uh-huh, I expected that." Because I'm pretty confident my family has an MC4R receptor deficiency. So all the testing I have applied to myself would validate this theory,
Mm.
which explains why I had a profound and powerful response to the first obesity pharmacotherapy medication that was given to me at doses that are very, very, very subtherapeutic. So
Wow.
I woke up in another person's brain uh, with
Wow.
a dose that shouldn't do anything, which got me to wonder, well, that's not normal. That's not. And then it allowed me to sort of see, and then studying for my obesity boards, starting to do genetic testing. So I actually do a rare monogenic obesity panel in people who have a BMI over
Wow.
40 and a documented history of long-standing hyperphagia, because I believe in 5 to 10 years, we will see this thing that I see more clearly. We have our monogenic obesity syndromes, which are very obvious and very distinct and clustered in families. And then we have our polygenic obesity, which is where there's thousands of alleles that influence a person's size. Up to 70%, somewhere between 60 and 70% of a patient's size, the whole thing, is determined by like multiple genes at multiple sites, right? So for people who are like, "Oh, I've only had successful treatment if I'm a size 2." It's like, no, under no circumstances would you ever be a size 2. Like ever. It would be dangerous for you to be a size 2.
Yeah.
But they don't know
Okay.
that because our culture is so destructive around weight, particularly women's weight. But now it's actually both genders or all genders.
Mm-hmm.
I believe that there is this slice of people in the middle. And I know this because I've started to see it in my practice, where people meet criteria for monogenic obesity testing because of the hyperphagia that is lifelong, the BMI that is lifelong, and lots of these people actually are responding quite poorly to first line pharmacotherapy. So the MC4R deficiency people respond right away, like rapidly, to drugs like semaglutide, liraglutide, tirzepatide. The people with the other monogenic obesity syndromes, quite underwhelming responses. And so for this group of people who don't have all of the sort of the genetic complement that would result in the full disorder, I have seen lots of people come back as heterozygous. So they have one or two alleles that are consistent with this syndrome. This happens mostly with Bardet-Biedl syndrome, which is actually a ciliary disorder that results in hyperphagia. And so a lot of my patients come back with their heterozygous at 1, 2, 3, 4, 5 sites. And the team that is conducting this monogenic obesity testing, they're in the States, they're at Johns Hopkins. They are building this first of its kind repository of genetic data. And I asked them actually at a talk last year, I said, do you think that we're going to find that there are these heterozygous people who don't have the visual disturbances, don't have the renal abnormalities, don't have the intellectual disabilities, but they are hyperphagic and their responses are underwhelming to therapy? And they said, yeah. So there's no trials on this. This is not stuff that is known. This is all hypothetical, right? This is just someone who's like elbow deep in the arena of obesity medicine being like, some patients don't respond to treatment. They just don't. Why? There are reasons, lots of reasons, and genetics is one of those reasons. And I think we can't just be like, well, who knows? I actually think we can go and figure it out. And so luckily for my patients who have had and been eligible for this obesity syndrome testing, their data is going to be reanalyzed when we know more. And I believe there will be therapeutics that are dedicated to helping those people with those kinds of presentations, even if they don't have like the full condition.
My gosh, this is so fascinating. I feel like we need like a 4-hour podcast recording with you.
Well, I'm going to start. I don't know. The only place that one would be able to go to start practicing now, there's nowhere in Canada where an obesity fellowship, for someone who's not like an endocrinologist, and there's not even a lot of endocrinologists who are like dedicated to obesity. Most of them are diabetic specialists. There are really great fellowships in the US. They're not open to naturopathic doctors as far as I know. Maybe I'm wrong. Happy to be wrong. But in terms of like, for people who are now, like how do you start doing this stuff as a generalist? Like how do you start? Like, half my patients want to lose weight. I don't know what's going on here. How do I get facility the way that I do with thyroid conditions, hypertension, cholesterol, the way that I am expected to have facility with all of those other chronic diseases? How do I get facility? So you can get really into the weeds here, or you can just do like good bread and butter primary care. Like,
right.
Yeah.
All of those things are very doable. Until then, we have to empower patients.
Oh my gosh. So much to get through. I want to ask you about medications because I know we can't have an episode without talking about these, even if it's just for a little bit. But we have these powerful medications now for weight loss. How do you decide when medications, if medications, surgery, if surgery are the right option for someone?
Yeah. The first, so the very simplest answer is that if someone meets BMI criteria, plus or minus a obesity-related comorbidity or complication, they are technically eligible. One is allowed to prescribe those drugs. And sure, right? Like I actually advocate for widespread access. Wonderful. The problem starts coming 3 months, sometimes a little bit earlier, depending on their conditions, where you're following the rule book, like you're following the rules from the textbook, and then nothing happens. And then, or like a complication happens, or they start vomiting, or they stop eating, or they start passing out. Like that's actually where you then have to start making nuanced decisions. And it's not complicated, but you have to have some of an approach. So if I imagine myself in the shoes of a new graduate, for example, which is the shoes that you guys are going to be in, it's very reasonable for people who meet BMI criteria to be on medication. I think what I teach in my program and what I'm going to be training people on is to how to cast a wide therapeutic or sort of wide diagnostic net, right? While also initiating therapy. So walking and chewing gum at the same time. What does your initial blood work look at? It's really important that you're looking for micronutrient deficiencies. We see really horrible anemia all the time in people who are eating red meat and supplementing, like they're doing all the things. Then we have to really consider, well, is there a malabsorption problem here? You have to really sort of put your thinking cap on and walk through this framework of understanding, yes, I'm going to treat the patient with this medication because these medications are actually really nicely tolerated. Most people find them, if they're introduced gently and over time they're gently increased, you're keeping people on the lowest effective dose. You are not being too aggressive with weight loss goals. You have done realistic expectation setting because people come in and they want to lose 100 pounds tomorrow. If you've done all of that and they trust you, right? And sometimes it's about they really have come for that prescription because they would really like some relief.
Yeah.
And if they're eligible, that's fine. Your job is to get them to trust you, to start asking the other questions and doing the bigger thing, right? Which a naturopathic doctor is actually very well positioned to do. I do want you to evaluate for thyroid dysregulation. It is rarely a cause of gain of weight. And you guys went over that in Katie's episode, which is great.
Yeah.
So the question for me is not like, should I start therapy? It's what do I do with therapy? And then you have to think about affordability. You have to think about long-term affordability. You have to prepare the patient that for most people, these are lifelong therapeutics, which is fine. Because most people think that they're a diet. And so they're like, I'm going on the blah diet, the Ozempic diet or the whatever diet for 12 weeks, like 12 weeks and 10 pounds or what, because like that's the only frame of reference they have.
That they know. Yeah.
Your job is to bust that frame of reference and to reframe the entire problem. You must do that in order to build trust and loyalty. You will create, and even if in front of you, they are like raising their eyebrows and looking at you like you're a moron, whatever, that's fine. They will have enough dissonance in their experience to be like, maybe they were saying something right. Maybe they know this stuff. And so what you then get to do, so the old rules about who is eligible for bariatric surgery and where bariatric surgery fits in the algorithm of treatment don't really apply anymore. Because for the first time, and this data is like, this summer, for the first time we have pharmacotherapy that is as effective for many people, potentially up to 50% of people, as bariatric surgery. And we have high rates of bariatric surgery failure because people are not adequately worked up and they are not adequately supported long-term, pre or post. So in my opinion, bariatric surgery gets to go to the side, but remains an important side for some people. I would never criticize bariatric surgery. I'll criticize the programs because they're woefully inadequate and they should be defunded. However, as a therapeutic approach, in the context of a high quality therapeutic program with the eye on long-term health and wellness, they are important. There are some kinds of bariatric surgery that should not be done because the rates of failure are too high, in my opinion, and the risk of complications are too high, in my opinion. But we have lots of people who go to other countries or other provinces and pay 30,000, 50,000, I don't, many thousands to have bariatric surgery. And then they are left alone. And then they come to your office and they say, well, now what do I do? So you have to know bariatric surgery. You have to make sure it remains an effective option. And it should have a role in our system. But right now in our system, for a long time, we've let bariatric surgery be the tail wagging the dog. And that's not acceptable anymore, in my opinion.
Yeah. I remember seeing my first patient in clinic in our 4th year, our internship, and she had bariatric surgery. And I remember just being like, oh my God, what do I do? Because she was asking me for this nutrition advice. And usually it's like, I love to talk about this stuff, but I genuinely didn't know. And neither did my supervisor. It was like,
they're really fragile.
Yeah.
But
it was.
They're usually down. They're usually like, all right, what could go wrong?
Well, we worked through it.
Love working with them.
Yeah. Oh no. And it was rewarding for me too. And to be able to, it was one of my first patients. So to really like throw myself in there was a big learning experience for me too. But I'm glad we touched on that. We're going to need you to come back for a part 2. I'm going to close off the episode with a really important question, but we're going to need you to come back because I feel like we just scratched the surface today.
No problem. That'd be fun. Yeah.
So tell us what gives you the most hope about the future of obesity care and individualized weight loss. I want to end on a really hopeful note.
What gives me the most hope is that patients are not giving up. They're just in there. They're finding ways to figure out what's going on here, and they're sharing. They're talking to each other.
Yeah.
Which I'm here for. It's great.
Yeah, absolutely. Well, thank you so much, Dr. White, for coming on today. I know you're so busy and just trying to get you in the schedule. I was like, we're getting Dr. White on. I'm going to make it work.
We're trying. I have a story about it taking so long. I will say last thing, my website is finally done. So if people want to know, like, how do I work with you as a patient? How do I get on the program? How do I work with you as a clinician, as a mentor? It's all going to be at ashleywhitemd.com. Very simple. And from there, you'll see all the options.
Awesome. And you're on Instagram as well, right?
ashleywhite.md.
We'll put it in the show notes.
One of those.
That's what it is, yes.
Awesome. Thank you so much, Dr. White.